Alaikum wa alaikum bikhair. Good evening. My name is Abraham Swayah. I'm a neurosurgeon, and we are transmitting live from here from Farah Medical Campus in Amman, Jordan. And the backdrop is another unique view from Petra, one of the world's 7 wonders. The topic for tonight is the middle cerebral artery aneurysm, the clinical, radiological, operative, and pathological correlation. So let's look at the middle cerebral artery. Middle cerebral starts here at the bifurcation of the carotid artery into anterior cerebral and middle cerebral. So this is middle cerebral on this side, which is the right side, middle cerebral on the other side. And here it is inside the sylvian fissure. So the carotid will divide into anterior cerebral A1 and middle cerebral. Again, for you to notice. So if we take just this side, the right side, so it starts from here, at the bifurcation of the internal carotid, and it goes through the sylvian fissure. And here, at the sylvian point, it starts to divide into 2 or 3 bifurcation or trifurcation. So optic nerve, the right optic nerve. On the left, we are looking for above, meeting to form optic chiasm. This is the posterior clinoid process. This is the carotid artery coming from the roof of the cavernous sinus, dividing into anterior cerebral A1 and middle cerebral within the sylvian fissure. This is the frontal lobe, this is temporal lobe. And what we see here is the oculomotor nerve and the oculomotor triangle going to the roof of the cavernous sinus. Close-up view, carotid artery. This is optic nerve. This is what you see in terional approach, frontotemporal approach. So carotid divides into anterior cerebral and middle cerebral. And middle cerebral is coming towards us in the sylvian fissure. This is a very unique view from Yazerjil book. I looked at it when I was a resident. I still look at it with admiration. It's a beautiful, it's his handwriting. Mr. Yazerjil, Muhammad Ghazi Yazerjil, is a Turkish neurosurgeon who attained fame internationally. He is the best neurosurgeon in the world. He is a neurosurgeon of the last century. He's 85 now. So this is the carotid dividing into anterior cerebral, another carotid dividing into middle cerebral, anterior cerebral. The 2 anterior cerebral meet here, anterior communicating A2s, and the branches from the internal carotid as it comes off the roof of the cavernous sinus into the bifurcation. We have the ophthalmic artery, the posterior communicating artery, the anterior carotid artery, and the artery for the tentorium. And here the middle cerebral is the M1, which gives you branches in the temporal area, and also branches that goes into the striatum. Of course, we have branches to the striatum from the anterior communicating, but also the most important branches are these ones, the striatal branches. And then it divides into bifurcation or trifurcation. So here you are, carotid divides into anterior cerebral, middle cerebral. These are the branches of the carotid. These are the branches, the lateral branches of the middle cerebral. These are the medial striatal branches of the middle cerebral, bifurcation, and then they go into divisions. When I ask the candidates in the Jordanian board, they don't know this. They should not pass, actually, because this is one artery they should know by heart. But the last exam was disastrous. I was asking them, where is the lacrimal gland? And they were pointing here. So a neurosurgeon doesn't know where the lacrimal gland is. So many variations. Not only that, you need to know the normal anatomy, but you need to know the variations of these branches and where they are. So the normal anatomy and the variations. Here it looks like a trifurcation, but you can see that maybe it is bifurcation, but these 2 are dividing very, very early, or like this. So many variations. And to be a vascular surgeon, or to be an interventional surgeon, this is basic knowledge. So many variations. I want to dwell on it. They are really massive variations. So look at the anatomy again. The carotid, this is the optic nerve right, optic nerve left, the optic chiasm, carotid dividing into anterior cerebral, middle cerebral. Middle cerebral is coming towards us in the Sylvian fissure between frontal lobe and temporal lobe. And at a certain point it divides into bifurcation or trifurcation. So if we look at it from the lateral aspect, so this is the ear, this is the orbit, and there is the greater wing of sphenoid. Here's the frontal lobe and temporal lobe. Here is the Sylvian fissure. So we open the Sylvian fissure, and here you are, the middle cerebral is coming towards us, and it's dividing into an upper branch, which is called frontal branch, and the lower branch, which we call lower branch. So upper frontal, lower temporal. And then when they go over the insula, we call them M2s. And when they leave the insula and they climb the cortex, they are called M3, and on top they are M4s. So here you are, M3, M2, M4. The same picture again. And this is what you see on angiogram, the carotid artery, the cavernous part, the intracranial part, anterior cerebral, M1, M2, M3, and M4. And it supplies, the middle cerebral artery supplies certain area of the cortex, but here is a bifurcation, and the frontal branch and the temporal branches are equal, so it's called bifurcation equal trunks. Here, the frontal branches, the upper branches are superior, these are minor, these are major, or the opposite. Or you can get the trifurcation, 1, 2, and 3. Supplies this area of the cortex, if you look at it from the lateral side, or if you look at it from the superior side or from the inferior side. So middle cerebral takes all this area, anterior cerebral takes this area, posterior cerebral takes this area. So we know now what is the middle meningeal artery. What is the aneurysm? What is aneurysm? Aneurysm is a localized dilatation in the wall of the artery, and most of the time it is at the bifurcation. Why at the bifurcation? Because it's a weak spot. Our good arteries dividing into two, there got to be some weak spot. That's why the aneurysm arises there. Type of aneurysms are the circular ones, the diffuse ones, or the dissecting ones. If the blood is coming this way, it will flow into the aneurysm and then goes this way. Look at the wall of the artery, it's thick here, it's thin, so this is the area where it ruptures. And when they rupture, they will cause subarachnoid hemorrhage. Let me show you what does that mean. I want you to imagine, of course, this happened with me in one of my cases, rupture of aneurysm during surgery. But I just want you to imagine that this is an aneurysm that ruptures in the head of a patient. You cannot put your finger, you cannot put gauze, you cannot put patty, you cannot put abdominal pad, you can do nothing except to close that aneurysm. This is optic nerve and this is the carotid and this is the aneurysm that has ruptured. So the only thing to do is to clip it with this technique. So when we have subarachnoid hemorrhage in the subarachnoid space, severe headache. What the usual patients say, أجاني صداع ما عمريش في حياتي شكيت منه، صداع زي كأنه واحد خبطني بإشي على راسي أو كأنه إشي وقع على راسي كبير. على غفلة. Sudden, severe, never been felt before. It's a bang, it's an explosion. Associated with the nausea and vomiting, stiffness of the neck, blurred or double vision if one of the cranial nerves are affected, photophobia, and even sensitivity to the noise or neurological deficits. Mind you that if 100 patients develop subarachnoid hemorrhage, 50 will die on the spot. they will die wherever they are, driving, sleeping, whatever. And only 50% of them would reach to the hospital. And out of this 50, only half of them will survive. So this is a bad disease. Treatment is either surgical clipping, as you have seen, or interventional therapy. So this is the surgical clipping, is to put this clip on the neck of the aneurysm so that the blood will not go to the aneurysm and it will not rupture. Or you can treat it otherwise. These are the kinds of clips. There are temporary clips, permanent clips, different sizes, shapes, angles. Again, this is from Neurosurgery book. Beautiful thing. All the aneurysms are put in one diagram. This is circular bolus, carotid artery, middle cerebral artery, anterior cerebral artery, posterior communicating, basilar artery, posterior cerebral, superior cerebral, basilar, vertebral, ICAP, etc. So these are the summation of aneurysms. The commonest of these aneurysms are in the anterior circular bolus. So this here is the commonest. Here, backwards, posterior are less common. Middle cerebral represent 33% of the anterior circular bolus. And the commonest part where we have the aneurysm is at the bifurcation. Again, simple question you ask in the board, what is the commonest aneurysm? And the candidate would not know even the middle cerebral artery where it is. They cannot pinpoint where the middle cerebral artery. They just know shunt and disc, and that's it. The aneurysm could be pointing superior, could be pointing medial, pointing lateral, posterior, inferior. It could be complicated like this. When you clip it or do intervention radiology, you don't want to clip these branches. You want to preserve them. So this is the difficulty in treating aneurysms. It's a microscopic surgery, can never be done with the naked eye. This is what you face. It is a nightmare. No one knows the fear that gets into your heart until you face an aneurysm. كأنك مقابل أسد وفاتح دمه وبده ياكل. It's either you or him. And you can see the fundus is very thin and it's pointing to you, I'm gonna rupture, I'm gonna rupture. And you say, what brought me here? شو اللي جابني اليوم لو إن الله ما خلقنيش أحسن. And this is the clip that you put on the aneurysm. When I speak about vascular, I have to speak about my bosses who taught me the vascular surgery and they taught me how to clip an aneurysm. Mr. Alan Richardson, David Utley, Lawrence Walsh, Shane Olera, they actually put the love of vascular surgery in me in the 80s. Also, Lindsay Simon, who also I'm very in debt for him for teaching me. This is us in Korea, this is my wife. Albert Roten, who taught us new anatomy. He taught the whole world new anatomy. He's like a father figure for me. Mr. Ghazi Azarjil, still alive, still functioning. Robert Spitzler, one of the most famous vascular surgeons in the world. He was a student of Charles Drake in Canada. Here we are in Austria. Here they are in my house. Here in my house, sipping coffee. He's a great man. Here we are together in the European Society, here in Oman, and so on. So when you intermingle with these people, you learn from them. Because whatever you do, at lunch or dinner, you don't speak about sports, you speak about aneurysms or my charms. So that's why we are dull people. Spitzler and others came and met with His Majesty King Abdullah. Vinko Dolins from Slovenia, again, is a famous man in the cavernous sinus, and he is a great friend of mine and my family, and he helped us in establishing the cadaveric lab in Jordan. And here we are في الحمام التركي في عمان تحت and مطعم هاشم. Osama al-Mufti, Syrian American chap, he's famous for skull-based surgery. Again, a great man. Juha Arnisimi from Finland, very famous man. He has done 5,000 aneurysm clipping. Eduardo de Oliveira from Brazil, again a famous vascular surgeon. Atos de Souza from Brazil, a great man. Here we were lecturing everywhere from Vietnam to Cambodia to China, everywhere. Hirohito Sano from Japan, and his student, Yoko Kato, who took the flag from him. Liliam Shaker, again from India, and the Skull-Based Society. And the group of Arab vascular neurosurgeons whom I'm proud to be friend with them, proud to say their names. Jafar from Iraq, Ali Krisht from Lebanon, Jack Marcos from Lebanon, Fadi Sharbat from Lebanon. This is Ali Krisht, and this is Jafar, and this is Jack Marcos. Famous, international, good vascular neurosurgeons. And Ali Krisht also helped us in the cadaveric dissections that we had. So there are two ways of doing things, either clipping it by surgery or by interventional radiology. And for this, I would ask Dr. Farida Radan to elaborate on this.
Thank you. Thank you, Dr. Brahim. It's a privilege to be here and to be with you today. Try to make this quick and easy, although the topic is wide, and actually we'll try to stick to the time as much as we can because it is a wide topic. So I'll cover multiple things. Dr. Brahim did cover a few of them, so we'll go over them quickly. But as he mentioned previously, everything starts with the history. And I have to start by this famous surgeon, neurosurgeon, Walter Dandy. He is the first neurosurgeon, and probably Dr. Brahim can comment on that, who actually clipped an aneurysm. And that was in 1937. It was a while ago, microscope wasn't there, but it was an innovation of treatment. Before that, the first cerebral angiogram was done in Lisbon, Portugal, in 1927. He was actually a neurologist and did that first time, and he did get a Nobel Prize, but not for that. He also worked, Auguste Moniz worked on theory of frontal lobectomy, and that's what he got his Nobel Prize for, but he is credited with the first cerebral. However, moving forward to the current area, the first time when we started thinking about coils and detachable coils, this Italian physician, Dr. Guglielmi, actually moved from University of Rome to UCLA, University of California at Los Angeles, and worked with one of the companies to create the first detachable coil, and that was used the first time in human being in 1991, and in 1995 was the first time this was actually got approval from the FDA. So history-wise, it's not that long. 1995 when we had the first approval for it. These are some of the giants of neurointerventional radiology, surgery, Dr. Bernstein, Brugge. Bernstein in New York, Dr. Brugge is in Canada, Dr. Byrne is in England, and Dr. Junius, who passed away 2008, was one of the pioneers in neuroanatomy as well. Moving quickly, talking about what aneurysm, Dr. Brahim spoke a little bit about this. Essentially, most aneurysm, these outpouchings form at arterial bifurcations. And the reason why they form there, the anatomy of the vessels there is a little bit different. There are poorly muscular layers and much more collagen and less elastic tissues. So they are more commonly forming there. Essentially, the wall of the aneurysm, the reason why it ruptured, it lacks essential internal elastic lamina at that area. It's a very weak area. What's left there is a little bit of intima and adventitia, and that's what Dr. Brahim mentioning, how it's very thin. Why it happens, there is definitely not a solid theory, but we know it's not congenital. Most of them are not born with. However, we know that hemodynamics and acquired degenerative changes, in addition to inflammation as a combination, cause these aneurysms. When you talk about hemodynamics, in the last 15, 20 years, we've been able to slowly study the actual flow in the aneurysm, going into it and coming out of it. And that actually proves in a lot of ways how the direction of flow is associated with the enlarging of the aneurysm and as well as thinning of the wall and formation of the aneurysm. In addition to that, there is much more evidence now. Inflammation in the wall of the arteries has a key role in forming these aneurysms as well as rupturing of the aneurysm. Now we have already studies in the end process to show that anti-inflammatories such as aspirin, now the most commonly used, is actually in some way preventive to rupture the aneurysm. It will prevent or decrease the risk of rupture. And when we studied the studies of the wall of the aneurysm, there is clear, intense inflammatory reaction. And that has been proven actually by vessel wall imaging. Now we're able to image the wall of the aneurysm by MRI, and we look at the level of enhancement, which reflects the amount of inflammation in the wall. And that's one of the predictors of aneurysm prone to rupture compared to ones that doesn't have as much inflammation. That helps us a lot if somebody come with ruptured aneurysm and he has two aneurysms, which one actually ruptured? Sometimes it's not very easy to decide, it depends on anatomy and stuff, but this is a very important clue to where to go from here. There are other factors that plays into the equation. I wanted to mention the familial component. It's a very small percentage of it, but it's important to remember if there are a family with two members who developed an aneurysm, there's a 17% chance of another family having an aneurysm, and this family should be screened. So not everyone with an aneurysm, the entire family we screen, but if two members, the chances goes up dramatically. Obviously, smoking has been established as one of the definite causes that increase the chance of causing aneurysms and, more importantly, rupture, and more importantly, recurrence after we treat them. One of the things that can happen when we treat aneurysms, they come back either by coiling or less likely by clipping. However, smoking increases that chance. Heavy alcohol consumption and obviously cocaine use. So prevalence, how often? It's actually much more often than you think. We probably are 50 in this room, and there is a very good chance one of us has a brain aneurysm. So 1 in 50 in the population has a brain aneurysm. Luckily, minority of these goes on to rupture, and that's the biggest challenge. But the number of aneurysms are much more than actually the ones that we see. They are, when they rupture, if you see a patient with an aneurysm, there is a 20% chance he has another one. So that's very important to remember, and actually smaller percentage have 2 or 3. Luckily, they are a little bit more common in females. So going to what age do we expect them? Typically in the adulthood. Actually, it's the most productive age, 4th to 6th decade. That's actually when the people are most productive. However, it's unfortunately when it hits. However, there is a subset of this aneurysm that comes in pediatric patients, and we have to remember that these are a little bit different in different categories, but in a different way. They are more common in males. They are typically large. They come with mass effect, but they definitely exist in children. Size, we categorize them according to small, large, and giant based on the size. The small, less than 10 millimeter, large and giant, 10 to 25, more than 25. The reason why this is important, it affects treatment. It affects the risk of things, of rupture. It affects how we treat them and the risk of recurrence after we treat them. Giant aneurysms are a small percentage of aneurysm. 2.5 centimeter and above is a giant aneurysm, but somebody with a giant aneurysm, not only it ruptures more often, it actually causes patients more often comes with progressive mass effect symptoms. They compress on nerves, structures, and they come with that, or they come with strokes because thrombus form in the aneurysm migrates into other arteries and cause stroke. It's very important when you hear an aneurysm to know where it is. Somebody say he has a cavernous aneurysm. That's very important to know that the likelihood of this causing a cavernous ICA aneurysm, the likelihood of causing a subarachnoid hemorrhage is almost 0. The reason, it's extradural, outside the dura, which is very important for us when we're talking about where is the location of the aneurysms. The margin is usually the ophthalmic artery. Anything below the ophthalmic artery, the chances of causing subarachnoid hemorrhage is very low. That's why we don't treat them unless they are causing mass effect, large giant aneurysms. They 90% of these aneurysms, as Dr. Brahim said, are in the anterior circulation, coming from carotid or bifurcation of carotids. They are much smaller, much less in number in the posterior circulation, in the basilar. The ACOM is the most common in the front, coming with the PCOM and then MCA. Shape, they come in different shapes, but in general, either you have the the saccular, a ball, or a fusiform dilatation of the artery. However, there are a lot of different shapes. These are but if you think of dissecting aneurysm, they come in so many different shapes. Essentially, you have a tear in the media where the blood forms there and start expanding. In acute phase, it causes subarachnoid hemorrhage. In chronic phase, enlargement start pushing on nerves and causing pressure symptoms. There's also the atherosclerotic aneurysms, where the entire artery will start dilate, most commonly in the basilar. These are disaster to aneurysm. There is not easy treatment for them. They involve the entire artery, and patient often comes with actually pontine or perforator strokes because of the thrombus that form along the wall of the aneurysm. These are very difficult aneurysms to treat with very high mortality. Blister aneurysm, a tiny bleb that forms on the wall of the carotid. I don't know if you are able to see this tiny with the arrow, but this is very easy to miss and very difficult to treat. It's a nightmare for the surgeons before the interventional techniques, and still a very hard thing to fix even with the interventional techniques. Before the flow diverters, you cannot put a coil in this tiny thing, but these patients come with a real subarachnoid hemorrhage and they will bleed again if you don't treat them. So these are different forms of aneurysm, and they come with different shapes and formats. Infectious aneurysms, different category, patient with infective endocarditis showing up with subarachnoid hemorrhage. I'm glad Dr. Montasser is with us here. I'm sure he has seen some of these. They are typically very distal, have nothing to do with the frequencies we talked about. They are very distal and very small arteries. As your cases? This one, no, this one is not. So this is actually very rare. I haven't seen one of these actually in practice yet, and I hope I don't. But yes. So this one is actually a patient that was having an endocarditis untreated. Accordingly, traumatic aneurysm happening in kids, and most often minor trauma or major trauma, and result in typically specific sites of injury at certain areas where it's close to the tentorium or the falx. So you have this subarachnoid hemorrhage will come not necessarily immediately, may happen weeks or months after. When you're already thinking about brain aneurysms, you have automatically to think, are we talking about ruptured or unruptured brain aneurysms? In my mind, they are completely different diseases to some degree. Anatomically, if you look at it, it's the same. But the way we look at it, the way we treat it, the way we think about it is completely different. Ruptured brain aneurysm need to be treated immediately, urgently, and large percentage of these ruptured ones are very small. On the other hand, if you have a non-ruptured aneurysm, there is a lot of debate when and how to treat it. SOA study, the international study for unruptured intracranial aneurysm, has studied that. We'll talk briefly about it. But there is a lot of debate about it. We use a lot of things to think, should we treat it or not, based on a lot of factors. We'll talk about it briefly. To talk about the evidence, why endovascular techniques took a long role, and now actually the majority of aneurysm being treated that way. This gentleman directed the first study that proved the benefit of it. Dr. Mullins was the director of the International Subarachnoid Aneurysm Trial, the ISAT trial. This trial was published in 2002. This was the first randomized trial actually to prove that the benefit of endovascular therapy and superiority to clipping in that situation. The one thing I will mention here, if you look, this is a busy slide, but the way this was done, which is very important to understand, an aneurysm comes in, patient with aneurysm rupture, a neurosurgeon and neurointerventionist will sit together and decide, this is an aneurysm that both of us can treat safely to some degree. So every patient, the answer has to be yes to be in the study, because if this neurosurgeon said this is too difficult for us to treat, a basilar tip, this is a difficult to treat aneurysm by clipping, it will not be in the study. So it has to be able to treat it by surgery or endovascular technique. Both of them agree, then they will include it. That's why if you look at the earlier number, from 9,500 ruptured aneurysm, 7,000 was excluded because either the endovascular specialist said, I cannot treat this, or the surgeon said, I cannot treat this. So this is very important to avoid bias. Most of these patients were low grade. These are different grades of subarachnoid hemorrhages, so they are relatively not in coma, because most neurosurgeons will avoid, and Dr. Ibrahim can comment on that, avoid clipping patients who are in a bad shape. because of the effect on them. Most of them were anterior circulation, because posterior circulation is typically much harder to clip than to coil. The results, in 2002, the results showed that there is a 22% absolute benefit of endovascular treatment over clipping when we compare the two techniques. So that by itself cemented endovascular technique as superior to clipping and these ruptured aneurysms, based on the way we said, and we describe it. However, we followed these patients. This is 2005 now. There continued to be benefit of endovascular therapy over clipping, less mortality. This is accumulative mortality over 7 years. The red line is the clipping, blue line is coiling, and you could see that endovascular has less mortality, despite there is a slightly higher risk of rebleed after coiling. So despite that, and when we calculated the risk of slight increase of coiling, still the mortality over the long term was higher with clipping. So that's why things moved forward. This was proven in 2009, almost 10 years after finishing the 2009 data showed similar things. This is a very a study, the Barrow ruptured aneurysm trial. Dr. Spitzler is, as Dr. Brahim mentioned, very famous neurosurgeon, especially vascular skull-based surgeon. Essentially, this was done in a way to prove the contrary. That endovascular therapy is better. However, they randomized the patients, and eventually their data showed 15.5% absolute difference in favor of endovascular therapy in their data. However, the conclusion said multi-center trial needed. Obviously, that was not surprises, but coming from Barrow, which is a big neuroscience center, was a very important thing. To not go too much into this.
Is radiologically the only thing that we do is coiling?
No, we'll go into that. We'll go into that. So unruptured aneurysm, different disease in my mind. These aneurysms could stay the same. So could stay the same, follow them up, nothing changed for years. They could, over years, slightly enlarge, eventually rupture, or suddenly enlarge and rupture. And we're really trying to figure which one is that. The International Study of Unruptured Aneurysm tried to answer that question. Which one should we actually focus on? Which one should we treat? Interestingly, when they did this study, there was group 1, group 2, group 1 that had no previous subarachnoid hemorrhage. If you have an aneurysm that's less 7 millimeter in size, and it was in the internal carotid artery or in the middle cerebral or anterior communicating artery, the risk of rupture was near 0. Even if you moved to 7 to 12, the risk was 0.5 per year, 0.5% per year. So the number were really low. So what we learned from them is there are patients who definitely we look at. Patients with posterior communicating artery aneurysm or posterior circulation, basilar aneurysm, very risky. PCOM aneurysm, very risky. So we looked at these factors. They describe if it's a basilar aneurysm, posterior communicating artery aneurysm, or ACOM. We really need to think about it. If it's more than 7 millimeter or daughter sac, basically an aneurysm on top of the aneurysm, what we call it's a contained rupture almost. So a lot of factors. So there is this is what a lot of us use, a score system to try to decide, should I treat this patient aneurysm or not, based on multiple factors. Not necessarily you have an aneurysm need to be treated. So that's very important to remember, because of the risks of treatment is not 0. It's never 0. This is a very important thing of us. When we try to treat, we think about, which is what's the neck of the aneurysm, that space between the parent artery from here to here, the space, that's what we call the neck, and the dome, how high it is. This is very important because traditionally when we put coils, that need to be a small neck to hold the coils in place so they don't come out. Things change. There is so many different ways to treat an aneurysm. Traditional way, putting coils and putting a stent through it, or using a balloon while we're doing it to hold the coils inside. Like here, essentially a catheter goes into the aneurysm, we coils, and then put a balloon to prevent it from coming out. We'll go over cases to show that. These are patients we treated. personally, this is a patient with a PCOM aneurysm. This is the internal carotid artery. This is the posterior communicating artery aneurysm here. Obviously, you see the subarachnoid hemorrhage. Again, you see the aneurysm right here. This is actually the microcatheter going from the groin all the way up to the aneurysm. We are inside the aneurysm. We look at the aneurysm from inside rather than from outside. What you see here is first the microcatheter. This is the small wire that helps us to reach there. And once we reach there, we start deploying these coils. This is the traditional standard coiling. We keep doing it until we fill the aneurysm completely and no more blood going there. In a way, we don't obstruct other arteries. So in the end of the procedure, I have to see that no more blood going there. Here, this is the posterior communicating, supplying fetal oxygen to the posterior cerebral artery. So we have to keep it open. So that part of the very proximal part of the neck, we didn't coil. The reason is if I coil it, I'll obstruct that artery. So that's an uncompletely occluded neck of the aneurysm because of the origin of the artery next by. So that's what we sometimes have to deal with. This is a balloon example of how we use balloon. This is a ruptured ACOM aneurysm, anterior communicating artery aneurysm. As you could see here, this big outpouching right there. And this is a wide neck. If we remember a wide neck, this is, if I just put a coil there, it may not sit there without obstructing the same artery. What you have there, from here to here, these two dots represent a balloon that's sitting against the neck of the aneurysm. Another catheter goes inside the aneurysm. We inflate the balloon across the neck, and we deploy the aneurysm we deploy the coils inside the aneurysm until we fill it while the balloon is there. The balloon gets inflated and deflated through that time in a way to make sure that these coils will stay stable when we remove the balloon at the end. And we do that a lot in ruptured aneurysm because stents are not, for a resident I mentioned, is not the first choice in ruptured aneurysm. And this is a very excellent technique. I use it most of the time, not only to protect the neck, but to protect the patient in case we have rupture during the procedure. Dr. Brahim mentioned the case when there was a rupture during procedure. And for us I'm not able to open the brain and control it, but I have a balloon sitting in the artery that if I have rupture, and we could have rupture during coiling, will inflate the balloon, control the situation immediately.
You have a number, how many times you coil?
Every time we know how many coils, but based on the size of the aneurysm, you have to keep filling it until no more blood is there.
Is there a maximum or more? There's no maximum?
No. You shouldn't stop until you feel that you occluded the aneurysm. It's like putting half a clip on the aneurysm rather than the other.
There's a danger of return that will go, atheroма will go.
It's part of the risk of the procedure. So with balloon-assisted coiling, you help avoid the issues of wide neck aneurysm. These issues were not, at the time when we did ISAT, there was no balloon part of it. So at the end, you don't have any filling of that aneurysm. Almost coming to the end, this is an example of a basilar aneurysm. Basilar artery, big aneurysm. Look at how wide the neck is. Whatever you put there, it will come out of it the minute you remove the balloon. So that's where the revolution came, where we started actually deploying stents designed for the neurovascular structures. Here we have what we call Y technique. Essentially, we deployed these two stents in a Y fashion. Essentially, you have two arms going into the posterior cerebral artery and the two stents in the basilar before we even put any coil there. And then we go through these stents and deploy the coil. The importance of this, preventing coils from coming out. And more importantly, we change the flow dynamics across the neck of the aneurysm by the stents. This is after stenting. Essentially, no more contrast, no more blood going there. Finishing with these type of aneurysms, and when you have this kind of aneurysm, there is no coil that's in there. There is no neck, essentially. These are giant aneurysms. For a long time, these were not having endovascular technique. This is a patient with huge basilar aneurysm, diffuse atherosclerotic aneurysms. Essentially, there is no endovascular techniques that I mentioned that would be adequately treating for these. Before, what were done, that the neurosurgeons will do a bypass for it. It's being done. Bypass is a major way of treating aneurysms. but it's really a complex procedure that needs a very high expertise and high volumes. What happens in the biggest innovation of endovascular therapy happened with coiling, and nothing happened for almost 20 years until we developed what we call flow diverters. It's a type of what looks like a stent that essentially prevent the blood from going into these large structures. We put it in the aneurysm, in the artery, so the blood goes into the artery and doesn't go into the aneurysm. These are examples. What happens when you deploy the stent into the immediately where we have stagnation of blood into the aneurysm. It's not a covered stent. Blood can go in and out, but essentially it changes the flow dynamics into that aneurysm. The other thing it does, it gives scaffolding that intima will start building over that mesh. This is another example. We have a large, big aneurysm. You deploy this, what looks like a stent. In 6 months, we'll repeat the imaging. Immediately, it's not protective. Patients can rupture immediately because it's not preventing blood from going there. It needs 3 to 6 months to have an effect, sometimes up to a year. And that's why we don't typically use it into in the ruptured aneurysm. Finishing here, this aneurysm try to treat the uncoilable, keep side branches open, less coils, and we treat what we couldn't treat before. This trial proved that we can do that and showed that this aneurysm we couldn't treat before, now we have very good chance of treating. And there's no delay there is no recurrence. That's the biggest thing with these aneurysms. When we coil, there is almost a 10 to 20% of chance of recurrence of the aneurysms. With flow diverters, the chances are very, very low. So that's the major thing we use. However, these patients need anticoagulation during procedure and need a strong antiplatelets for treatment. Finishing with these 2 slides. Rupture aneurysms are never easy or never one thing. Every patient is different. This is a patient we faced, and I'm glad Dr. Ibrahim is here. He could see the images. And this is to show how there's no real strong rules. This is a big intraparenchymal hemorrhage from an MCA aneurysm. MCA aneurysm can rupture into the parenchyma and give you not only subarachnoid hemorrhage, intraparenchymal hemorrhage. Small neck, how would you treat that? Should we start by drainage, EVD, the ventric? Should we evacuate the clot? You have an aneurysm. Should we clip the clot immediately or go and coil? There are so many different ways of doing it, and everybody would do it differently based on what? Based on the clinical picture of that patient. So at the end of the day, this is a team approach. And honestly, it's almost incomprehensible to do it as a one-man show because you cannot. You cannot serve the patient in the right way that way. In the end of the way, it's true there's so many ways to skin the cat, but you have always to think of your local culture. What's the best expertise in that place, in that hospital to help that patient? In the end of the day, with every aneurysm, you have to think of the patient clinical status, of the anatomy. The anatomy truly tells you where to go and what kind of expertise you have in that place. That decide which way to go. Thank you so much. I really appreciate it.
Okay, so we showed what is aneurysm. We talked about some anatomy, and we showed that they can be clipped by this surgical method of clipping, or they can be treated with many interventional ways that Dr. Adam mentioned. So it was sort of revolutionized at every step. I'm so interested in this that in Paris or in other places, there is a meeting every year at the Louvre, and I attend that and make it a point to attend. It's interventional and neurosurgical. So we sit there, we fight, we exchange ideas, and you get more knowledgeable when you go out. Just looking at this, Dr. Adham mentioned this story. Let me summarize it. In the 80s, when I was having my residency in England, there was nothing called coiling. It was only clipping. And the clippers, the neurosurgeons who clip aneurysm, were the famous, the most respected. And if you are a resident in training and you get an aneurysm to clip, then nobody can catch you. You walk in the world, ماشي هيك. أنا امبارح عملت aneurysm. I remember being given the first aneurysm in my life, 6 months into my residency. And the whole world could not take me. I was so glad that I could do an aneurysm. But then came the ISAT study, and then things started to change. You have to accept change. The interventional radiology gives you better results than the surgical results. Although Dr. Adam mentioned that the risk of rebleeding is more in the coiling rather than in the clipping, but still, all in all, it's a good way of doing things. We are not enemies. We sit together and discuss what is the best for this patient. Can I do it? Can he do it? Or we can't do it, send him somewhere else. It is back to your honesty and integrity to decide what is the best for this patient. One area is that somebody puts a coil and it ruptures. Then the only way to do is to do clipping of this aneurysm with cords in it. So difficult because you cannot put a clip. It's hard with these cords. So there is a new era of surgical treatment of coiled aneurysms. Like it is really difficult. So let's speak about this patient that we have prepared for you.
So what's the material of the coiling?
Material of the coiling.
Most of the time it's platinum, but it changed from the one thing that happened dramatically between before and now. Most of the clips before were some form of metal that will prevent patient from having an MRI. Now things change. For us, it's always an MRI safe, and I'm mentioning that for every radiologist. So platinum is the largest component of that metal inside.
So the clips and cords are now MRI compatible. So this is a 51-year-old male Jordanian who lives and works in Saudi Arabia, and he complained of sudden headache that was followed by loss of consciousness for 30 minutes back in Saudi Arabia. When he woke up there, he was confused and he had seizures and he had double vision. And his past history, he had hyperlipidemia on Lipitor. And interesting enough, 2 years before that, he was diagnosed to have a stroke on the left side. This was actually not a stroke. كلمة stroke عندنا في البلاد العربية is ugly word. كل شيء stroke. And they are not actually looked at carefully. This man had subarachnoid hemorrhage at that time, and he was diagnosed as a stroke. For stroke is a very peculiar word. Heavy smoker, so all the criteria, heavy smoker, hyperlipidemia, and no alcohol ingestion. As Dr. Adam mentioned, it is more in females, lucky for us. And in females, when they have their subarachnoid hemorrhage, most of them, they are on the contraceptive pills. And this is very interesting. In males, when they have subarachnoid hemorrhage, 25% of them had subarachnoid hemorrhage during sexual intercourse, which shows you how dangerous that is.
Or shitting, actually. Or straining, yes.
Vital signs, he had hypertension. He had basal crepitations. He was agitated and confused. He had right signal palsy. In fact, he came to Jordan without being diagnosed as subarachnoid hemorrhage. He was diagnosed as a stroke. صار عنده stroke زمان هلا stroke ركب الطيارة ومشي ووصل في stretcher. He arrived to Jordan about 2 weeks after his subarachnoid hemorrhage. We love to operate on them as early as possible, but he came 2 weeks later. No weakness in his limbs, bleeding, kidney functions, liver functions. Okay, and this is his CT scan. What do you see? The blood in the interhemispheric fissure, blood in the Sylvian fissure on the left, but more blood on the right side. So we learned, and there is blood in the basal cisterns. We learned to diagnose the cause of hemorrhage by just looking at the CT scan. I would never call this hypertensive bleed. I would never say that this is an AVM rupture. I would never say this is due to coagulation process problem. This is a middle cerebral artery aneurysm rupture. So we could tell from the CT what's going on. also blood in all the basal system, but more in the cerebral fissure right. So 99%, this is the middle cerebral artery aneurysm. Angiogram, indeed, this is the carotid, the cavernous part, the intracranial part, anterior cerebral, ACOM, A2s, middle cerebral, and bifurcation. There is many lobed aneurysm at the bifurcation of the middle cerebral. And you can see it's pointing downwards and lateral and anterior. So not only you diagnose aneurysm, but you have to imagine the aneurysm, how many lobes, where it is directed, where is the fundus, because the area of danger is the fundus. As I mentioned before, if 100 of us are sitting here in this hole, and the 100 of us develop subarachnoid hemorrhage, 50 will die here in this hole. The other 50 will go to the hospital, 25 will die later. Only 25% of patients will survive.
Can you tell which one ruptured?
This one. It is the same aneurysm. It is the same aneurysm, but as answering your question, if I have multiple aneurysms, say I have one here, one there, and one here, which one has rupture? I see where is the blood, what is the direction of the blood, and as they say, the more lobed it is, the more that it has ruptured, and the more it is proximal, the more it has ruptured. So you can tell. So here it is. So this is danger.
So how come it stayed alive this one? What was this?
Just like pure luck. You had swish. إنه يركب الطيارة ويجي الكابن pressure, the whole thing. Most of the subarachnoid hemorrhages that I have treated in Jordan, they came walking into my clinic. Essentially, they have headache. Shows you how backwards we are in terms of diagnosis, and that we are proud of the progress of the medicine in Jordan. We should be also shamed by the not diagnosing these things. Chest X-ray, ECG were normal. We did a few consultations. Actually, this was 2001 or 2, and the patient came to Jordan Hospital, and Dr. Mawi Arabna was there, so I asked him to see the patient. Of course, I sat with the family. There is something called interventional radiology. I sat with the family, what do you want? We have interventional radiology and we have surgery. Most of the time, people would choose interventional. Those people said, no way, we want surgery. We want this to be clipped and want to fly back to Saudi Arabia. So, Mawi.
Thank you very much, Mr. Ibrahim. As always, thank you very much, Mr. Ibrahim. It's a pleasure working with you. طبعا, I've been in this business for long enough. I'm just about to finish my career in anesthesia in a few years' time, inshallah. A few things, no matter how many years I've been in anesthesia, I feel every time it's first time, hand on my heart, and this is an exam for me. Am I going to take this exam or fail this exam? Subarachnoid hemorrhage, clipping, cabbage مع valve, لأنه 50-50 chance إنه يروح من بين إيدي, cervical epidural. These are three things I wish every time I never see them again. Every time I do them, بصراحة يعني. لأنه every time is first time, no matter how you do them, and this is one of them. Unfortunately, he said, I've anesthetized many of them in England harvesting subarachnoid hemorrhage. It's heartbreaking. لأنه as Dr. Farid mentioned, هذول بيكونوا peak of their age, peak of their العطاء تبعهم, healthy, wealthy, ما معهم شيء. All of a sudden, بعدين they are organ donors. All of a sudden, you have to convince the family organ donors. We spend all night on it. So it is very bad. I wish I didn't even talk about this issue because it's very hard-working. Just a few words. في صار في overlapping. إحنا ما شفناش محاضرات بعض بس. It's most, although most cerebral are asymptomatic, discovered incidentally most of the time. لأن Dr. Farid mentioned كمان إنه كل 50 فيهم واحد. But when it's rupture, it results in significant morbid mortality, unfortunately. And we become, as an anesthesiologist, we become involved in clipping, and coiling, and rupture, or at any stage of subarachnoid hemorrhage. Again, same thing. الستاتستكس تبع الدكتور ابراهيم شوي مختلف لانه probably بتعتمد من وين تيجي. 2/3 get to the hospital if you are living in a better place. إذا كنت في عمان وأزمة زي امبارح forget it. 0% توصل للمستشفى. 0% I can guarantee. إذا كنت بتعيش في مدينة متحضرة وهذا توصل في 70% chance. So it depends where the third of them in hospital severely disabled or حتى اللي بوصلوا يعني بموتوا بالمستشفى. It is urgent operation and not emergent case. وهذا for my colleague mediocre colleagues اللي بيجوا يشخصوا بالأشعة بالتصفيق بقلب الدنيا بطلع مش عارف ايش والمريض بكون هذا طبعا recipe to kill the patient له انت بتكون already your hands on the heart. Am I going to pass this؟ وهو بحط عليك بريشر بتصل فيك من الأشعة جهز بيها طلع ليها بدون ما تشوف not prepared تاخذه مشان تقضي عليه فوق. It is urgent but never is an emergent. عبين ما انت انه to sort him out. Never is urgent for us. Our goals to prevent aneurysm rupture. بصراحة الجولز اللي بدي أحكي لك إياها ما ترفع ضغطه، ما تنزل ضغطه، ما تعطيه فلويد وأعطيه فلويد، ما تعمل له hyperventilation وأعمل له hyperventilation. I don't know how but you have to do it. I don't know how but these are the goals. كل اللي بحكي لك إياه عن جد ارفع ضغطه بس نزل ضغطه، أعطيه فلويد وما تعطيه فلويد. بس these are the goals يعني you have to play. Because you have to avoid changes in blood pressure. Sudden changes in blood pressure خاصة على الاندكشن يعطيه العافية هو راح يفوت ومش عارف بس already انت you finish the patient وهذا وسلمته مريض already rupture ومنتهي وهو راح يفوت ويشتغل إذا إنه صار في عندك changes swinging على البداية. Decrease intracranial pressure again with your intubation with your هذا. Maintain cerebral perfusion pressure at all times if you can more than 70 millimeter mercury if you can because نتكلم هلا برجع لها بعدين. And prevent cerebral ischemia لأنه he's going to put too many retractions زي ما شفتوا هذا عبين ما يوصل له تسديد. And good operating condition. If you don't facilitate his work, he will never reach the aneurysm. So no movement, بدك very well relaxed, brain soft, relaxed, and he want to expose it. These are our goals. طبعا we've got armada of drugs to help you. Nitroglycerin, esmolol, short-acting vasopressor, really كله available موجودين عندك remifentanil nowadays. Most sometimes خاصة إذا كانوا له several days إذا كان المريض موجود على نيموديبين will make your life much more difficult. وإحنا شفنا مرضى من هذول لأنه he will tend to be hypertensive all the time أنت بدك ترفع most of the time to keep CPP. if he's in medication وإجا قاعد الفيزيشن حطوا له this is make our life even more miserable. Usually preoperatively they are either symptomatic or asymptomatic. It depends. في عندهم subarachnoid hemorrhage it depends on subarachnoid hemorrhage grade and if there is any myocardial effects and هذا زملائي كلهم the tendency they will have some myocardial effects. Please look for it. هلا برجع لها. They are possibly intubated. Location size of aneurysm where is it? Intracranial mass effect and neurological deficit and symptoms and timing. لأن timing مهم إنه نعرف إمتى صار هذا الرابتشر لأنه التايم هلا برجع له إذا صار recent لأنه maybe there is a good time for us to escape from vasospasm وإذا كان له several days بتفرق كثير ما راح أطول عليها بس the subarachnoid classification from grade 1 to 4 مشان نشوف إنه grade 1 زي SA best one grade 4 is the gravest one. Preoperative not much really. one IV لأنه they bleed like hell له ماشي بس not torrential bleed اللي إنه بيحتاج لهذا يعني you need only one IV. You need if he's anxious لأنه شباب وزي ما حكيت well off probably it's good if you want to pre-medicate him لأنه صراحة مرعب الوضع. And remind of potential post-op intubation خاصة إنه إذا كان حسب الجريد تبع السبركلودول whether he grade 1 2 hopefully he will be extubated but if he's a grade 4 he will be intubated. I'll consent for intubation لأنه ما راح أقدر أصحي. Adequate fluid loading اللي هو just the bare minimum 5 to 6 millimeter per kilogram. Induction ما راح أطول routine monitors وزي ما بنحكي arterial cannula before intubation لأنه most important things blood pressure. تحكي عن aneurysm very thin wall عنده subarachnoid اجى aneurysm وهذا we don't want to rupture it right at the beginning وهو احنا مش عارفين انه rupture من هذا. طبعا smooth induction smooth method smooth extubation هذا برجع لك how you going to run the smooth وزي ما حكيت you've got armada nowadays of medications to do all this and you can. Critical period اللي هي may feel pins وزي ما بتشوفوا بنعمل مع الدكتور ابراهيم all the time انه بستنى عليه بعد put some locals على اساس ما you don't want this swinging in blood pressure لانه one pen لما يحطه if the patient is not deep enough his blood pressure will surge from 100 to 300 once immediately. Skin incision, periosteal flap is extremely painful. Otherwise, bone is not painful except the periosteum. So when you want to start to do elevation of periosteum, has to be deep. These stimuli might cause increased blood pressure. Hence, narcotics and propofol is advised. Maintenance, moderate hyperventilation. End-tidal CO2, 30 something. I don't know قديش. هلا برجع لها. millimeter mercury. Eovolemic ringer lactate 500 as I said minimum, but you need it. Probably moderate hypothermia is good 35 degrees centigrade لأنه بتعمل decrease in oxygen consumption metabolic rate.
So you ice him down.
We don't ice. الفلتر هو نفسه بارد عادة بيشتغل على 17 ما بنستعملش heating active heating so will be passive cooling.
Like question. إنه ما عندي فكرة بس المورفين is a good vasodilator من الهستامين ريليز. إذا أعطينا المريض pre operation المورفين شو بصير؟ يعني مش شرط مورفين ميبيريدين أو إيش
عفوا رفعت ايدك مشان جاوب؟
لا بدي اسال كمان لانه بنفس النقطه هلا في ادويه محدده السيربرال انيوريزم كليبنج بتختلف عن الانتراكرينيال تيومرز اللي كلهم يتعامل فيهم نفس الشيء.
ايش يعني بالانستيزيا؟ والله هذا بيعتمد على ذوقك حكي يعني كلياتهم زي ما حكى في مورفين في فندل what you are using best please do use it اللي تحافظ على البارامترز اللي حكيت لك عليها.
فهمتني يمكن اما
ما راح ادخل فيهم هلا لانه هذا موضوع حكيم بس اللي انت بايدك احسن شيء بيشتغل بايدك ومتعود عليه and you guarantee you are not going to have swing in blood pressure وبدك اسمه هذا please do use it كتار بس بعديها ممكن نتكلم فيه بعد المحاضره.
This was already ruptured.
Yes, this patient.
already ruptured بس مش معناه انه خد راحته.
Just don't want it any further bleeding.
يعني شكرا ربشة خلص يعني طيب نرجع للانتايدل كربون دايوكسيد وانا بحكي للريزنتس اول ذا تايم من سم بوكس وكنت اسال بالبورد زيك انه قديش الرينج سوري قديش الفاليو اوف كربون دايوكسيد بحكوا الرينج من 35 to 45 ايش مكتوب بالكتب I said it is never it is 40 it is 40 from day 0 till you are 100 years old it is 40 it can't be لأنه your brain, your respiratory center will sense 0.1 millimeter mercury changes of acidity and carbon dioxide. الله ما راح يعطيك شيء في range 10 millimeter mercury was going to sense it. Otherwise ما راح يعيش. So it is not, regardless whether written or not, but it is 40. This is normal carbon dioxide tension in the blood. فيش في range at all. Cerebral flow drops 3 to 4% for every millimeter. لو كان في رينج يا اخوان how are we going to drop the cerebral blood flow اذا في رينج 10 فاضي واحنا بقول في عندنا drop 3 to 4% for every millimeter mercury. But I want you to remember this يعني لما يكون وهذا for our my في عندي كمان mediocre anesthesiologist انا بتذكر انه في واحد دكتور عزيز علي قبل few months توفى والده دخل مستشفى في هاي البلد بده يعمل very simple operation بس ابوه كان بال90s bladder stone عملها بعدين طلع ابوه مش ابوه لانه الكربون انتايدل كربون طبعا when you are old your carbon dioxide لما يوصل 29 ملم mercury you could imagine cerebral blood flow قديش بده يكون almost 10% ولما تكون 90 already في عندك سكلروز في عندك مشاكل بيكون 0% بيطلع من العمليات total anyway he died afterwards لانه many complications. فلما يكون عندك انتايدل كربون دايوكسيد 30 ملم mercury اللي هو كنا بالزمانات وانا واز ريزيدنت كنا بالجامعه كان يعلمونا انه تعمل 30% انت you are talking about 40% decrease in cerebral blood flow already brain traumatized وفي عندك vasoconstriction وفي عندك problem وفي عندك another 40% decrease هو هذا decrease this is recipe for the patient to يطلع عندك بالزيرك or banana يطلع موزه انسان اخر. So for each 1 millimeter في عندك 4% decrease. So this dangerous. As may be drop as well as much as 50% from TBI, traumatic brain injury. So there is traumatic brain injury already. You've got 50% decrease in cerebral blood flow. With the anti-amyloid 30, if you add another 40%, patient left with only 10% cerebral blood flow. For carbon dioxide tension, internal carbon dioxide is extremely important in any operation, but especially at extreme of ages. لأنه you might end up with وعشان هيك في قطاع اللي بيطلعوا بعد عمليات هذا totally different persons وبيضلوا عليهم مش راح تعرف وين هم ومين هم. هايبر فنتيليشن طبعا احنا هايبر فنتيليشن انا سوري I hate كلمة. I think carbon no less than 38 for me. Hyperventilation is high controversial still. When we do that, but Cochrane database, probably they recommend no less than 30 millimeter mercury. Whatever you do, لأنه إذا في عندك هذا لأنه with each millimeter mercury drop, the chances of ischemia عندك تطلع paradoxically.
Like that, in breathing, is it? لازم أعمل hyperventilation عشان أشيل CO2 in breath constriction. أدير بالي ما أعمل hyperventilation. It's not.
بعرفش حكيم سؤال بس نو هايبر فنتيليشن ان شاء الله ايش ما كان يكون لانه كاتب لك ما فيش هايبر فنتيليشن. هلا at the time of لما يوصل الدكتور احنا هوبفلي انه المريض زي ما حكيت لك نورموفيلينيك نورموتنسيف نورمو مش عارف ايش وهذا ودخل بده يوصل للانيوريزم. You have to decrease blood pressure شويه على اساس اول شيء يقدر يوصل لهذا. Pressure usually inside aneurysm because at arterial levels it's usually induce hypertension during the time of dissection and clipping. بتريح المريض وبتنزل له عشان يقدر يوصله. And has been found that aneurysm and its vascular tree are more mobile at mean arteria of 50 millimeter mercury. كثير بكون اريح له وبوصل له والانيوريزم بكون زي القله بتروح تيجي بقدر يوصل للكليب at around of 50 millimeter mercury. It is important that mean it's measured at the level of the brain. هذا كمان حكينا هذيك المره اللي بصير فص خاصه اذا بيعتمد الترانسديوسر لانه with each زي ما انت عارف كل سنتي بنزل عندك الريدنج فما يكونش 20 سنتيمتر below the patient brain level بكون كل الريدنج اللي عندك بكون false. You have to check with the transducer to be exactly the same level. Where is the surgeon going عشان يقدر تحصل على this fat. The usual thing is to reduce mean arterial pressure to 60 millimeter with the surgeon approaching the aneurysm and go to 50 millimeter with clipping. زي ما حكيت بصير كثير أريح له ومبين and he will have a very good view. Unusual choice for is between nitroglycerin, sodium beta blockade. وأجين هذا شو اللي بإيدك منيح please استعمله. I'm not going to suggest anything. What is best in your hand? Please do use it. They tried to use hypothermia. Survival issue has been shown to be prolonged, profound hypothermia. اللي had active cooling, 20 degrees centigrade. It felt that there might be in this type of surgery. Unfortunately, it has been proven very rarely used these days لأنه ما في أي benefit or improve in mortality or even mortality. Reason لأنه زي ما حكيت there is no benefit. Clips في زي ما حكى هلا ورجع في عندنا الجولدن لو temporary clip وبعدين permanent clip وبحط بالأول على أساس إنه يشوف وبحذرك وبحكي لك communication is golden thing between you and the neurosurgeon all the time. In this case particularly all the time in any communication but specifically in this case communication مشان تعرف شو اللي تسوي لي إياه وهو شو اللي يعمل لك إياه. Aneurysm manipulation before usually the bleed. بعدين we have to record the clip time on and off مشان نشوف إنه إذا صار في إشي. Maintain cerebral perfusion pressure at the clipping and then start closing and hopefully everything is fine. Now he put the clip like that and once the clip is in aneurysm clip blood pressure is raised to pre-operative level. So بعتمد عندك إذا المريض عنده chronic hypertension وإجا والكيرف عنده رايحة على الرايت برفع على الرايت على أساس يكون هذا. This should be done slowly over 10 to 20 minutes. إما بتخفف من narcotics وهذا بتوصل لل pre-operative levels اللي كان عايش عليه. Fluid prior to end of surgery unless was marked cerebral edema pre-operatively. Maintenance of adequate filling pressure, blood pressure will help prevent vasospasm becoming clinically significant. Rupture. What happens with that? If an intraoperative rupture does occur, anesthesia may be required to do any of the following. لأنه إذا بيحصل زي ما ورجع ببداية السلايد لما بيحصل rupture it's sheer nightmare زي ما حكى. ما في لا تقدر تمسكه ولا تعمل اي شيء ولا تحطه ولا هذا. you have to induce, you have to decrease blood pressure, you have to help him لانه هذا this is an artery and في عندك فهمت النافوره شغاله all the time. Sometimes which is novel more recent, adenosine arrest is fantastic in this situation, especially in bleeding. Or place manual pressure on the ipsilateral carotid might decrease, although هاي لها مشاكلها. We prefer adenosine arrest. If significant dependent anticipated hypothermic arrest may be planned, arterial venous access وgo on the pump. خاصة إذا شفته عزيز عليك وشبه هذا why not؟ وهالأيام كل المستشفيات فيها. إذا إنه كان البليدنج توريشن بليدنج وما قدر وما راح يقدر otherwise البرين كل البلد راح يطلع من البرين وما راح يوصل له هذا. ask for help bring وهاي بتكون عندك next door. حط له اطلب حد من الريزدنت تبعون الكلب وحاولوا على البامب وبصيروا and has been used it is successful by the way. median dose طبعا الادونيزين arrest 30 ملي جرام بعطيك 30 seconds of heart rate less than 30 beats per minute which is fantastic. وهو هاي 30 seconds واحد زي مستر جونزاليس I think بوصل لهذا added to him but you will have 30 second arrest with 30 milligram of adenosine which is fantastic. Toward the end طبعا CO2 normal وأنا مع النورمال right from the beginning لأنه I don't believe in any decrease. Dura closed area, lots of intracranial spaces, normalized blood pressure. The recovery patient should be assessed in recovery ward, return to intensive care بعد ما شافوا fully neurological problem. هلا بص في عندنا few worries. Vasospasm. It is almost nightmare and it happens in all rupture aneurysms. Rebleed is another problem. Infarction either due to clip clouding or vessel to thrombosis. And higher risk group there may be continued decreased level of consciousness and usual complication occur, pulmonary edema. Post-operative fluid status, just to keep good urine output. بدك تعطيه هذا no more no less. Close eye and electrolyte status لأنه hyponatremia it might occur and usually does occur. Potential complication delayed awakening from anesthesia لأنه زي ما حكيت we've used lots of drugs لأنه في عندك phases hypertension normocapnia وهذا it takes longer time than usual craniotomies. Cerebral ischemia, retraction, temporary eclipse and vasospasm, brain swelling, rebleeding, incidence of oxygen 8% and this highest at the يعني حتى البوست-surgical هذا بدك to be in your toes 3 days later. أول الثلاث أيام هاي بدك تضلك تتوقع إنه ألو ساعتين بالليل تقدر تجيني بسرعة هذا بدنا مش عارف إيش because 3 days and the highest within 72 hours. Associated with morbidity and mortality. If there is a rebleeding أنا بتهيألي you have to make another consent وتشوف لأنه there is a rebleeding المortality will go exponentially معك ومع يلا خلص. 23% of these patients will have neurogenic pulmonary edema راح يصير عندهم pulmonary edema عشان هيك be aware بالفلويد and respiratory complication. Second most common cause of death will be respiratory بعد النيورولوجيكال. Potential complication cardiac dysfunction usually are related to the severity of neurological injury زي ما grades إذا كان for it's a must you will have some cardiac due to catecholamic surge leading to subendocardial necrosis. ECG abnormalities راح يكون عندك ST segment changes T wave وبعدين any Q wave always indicates significant myocardial injury. Any new Q wave it means إنه المريض صار عنده myocardial injury. Always إذا صار عنده day 3 day 4 Q waves معناته المريض صار so you have to consult your cardiologist لأنه صار عنده من هذا. Hyponatremia syndrome طبعا وزي ما حكيت بتحصل فيهم كثير. بس a few words about the vasospasm. وزي ما انتم شايفين leak blood على الارتري والارتري صار 1/3 of its distance. It is one of the worst problems in the condition causing ischemia. Subsequent cerebral edema further comprises the cerebral circulation. بس بدي احكي كلمتين معلومه مهمه كلمتين طولنا عليكم مش رح اطول. Radiological evidence of large vessel constriction is almost 80%, almost all of them بالرupture في عندهم vasospasm. Clinically, hemodynamic significance in 33% starts in day 3. That's why تذكر قلت لكم التايمينج مهم. لانه اذا كان عنده السباركنويد اليوم الصبح وهلا انت جاي بعد الظهر الفازوسبازم was not there. This is golden period for you. Peak 7 to 8 days and day 21 due to blood breakdown. ليش بيحصل؟ بس انا بدي احكي عن انا I think we should turn. طبعا بيحصل because of oxygen. بيحصل because of oxygen free radicals اللي بيجوا. حطيت لكم هاي التفاحه بتتذكروا اذا بتقسموها بتحطوها تتعرض للاكسجين to be got oxidized or to be ruined in no time. إذا بضل سكن عليها بتضلها موجودة. Same with oxygen. Oxygen radicals it's catastrophic. وأنا I think إنه we should لازم يكون عندنا neutral زي ما عندنا bile leak وكايل leak we should have some oxygen leak. والأكسجين وأنا عملنا محاضرة إن شاء الله برجع لها بعدين طلع بالجاردن بس sorry last week على الأكسجين وحكينا لهم عملنا محاضرة إنه oxygen could kill. انه you don't need 800% 80% بالجارديان الاسبوع الماضي طلع Anesthesia say patients at risk after flawed oxygen guidelines اللي هو 100%. هاي الاسبوع الماضي اللي طلعت بالجارديان. فالاكسجين والاكسجين راديكالز وهلا كمان lung contusion وحكينا عليهم بالتروما lung contusion probably if you do wash out قبل الثلاث ايام من الاكسجين راديكالز you do well for the patient والهايبوكسيا in the lungs. المانجمنت hypervolemia, hemodilution, hypertension, CVP 10 mm mercury, CVP زي ما حكينا above 60, blood pressure systolic above between 160 to 200 and hemodilution hematocrit 33% اللي بدهم يكونوا. So to conclude خلصت ابراهيم طولنا. Anesthesiologists caring for cranial aneurysm should follow 4 main principles. Number 1, acute increase in aneurysm transmural cranial should be avoided at all times. حتى لو rupture لأنه if it's rupture you make it worse. Second, CPP should be maintained. Third, surgical exposure should be optimized by providing brain relaxation. Early emergence is favored لأنه مشان بدك تشوفه وتطلعوا على هذا. And patient with cerebral aneurysm present unique challenge to anesthesia. Trust me زي ما حكيت لكم والله every time is first time. No matter how many patients you anesthetize, every time is first time. Every time is an exam for you. You're going to succeed with this. He's going to put the clip. Patient is going to get awake or not. Every time is first time. Anesthesiologist should have thorough understanding of pathophysiology of subacute hemorrhage. لازم تعرف كل المعلومات. Communication with neurosurgery is paramount. عن جد is paramount. Timing وإمتى حصلت وإمتى بدنا نعمله وإمتى بدي فوت بالكليب. It's complete. It's totally. And there will always be patients who, despite our best efforts, fail to benefit from surgical procedure. However, proper planning of optimal result can be hoped for. Thank you very much. لا الادرينالين one time shot الادرينالين half life anyway is around 20 seconds. Okay.
سؤال سريع عن الاكستوبيشن. Do you try an extubation in theater for every patient?
Not every. The grade 4. Sorry, say grade 1, 2 definitely. Grade 3 it depends. بطلع عليها بس 4 not. لا لأنه 4 لأنه زي ما أنت عارف every time extubation will increase mortality with 0.5%.
بس برجع لسؤال مروان about ruptured and unruptured aneurysm. We said that if you have 100 patients and they have subarachnoid hemorrhage due to ruptured aneurysm, 50 will die on the spot, and the other 50 will reach to the hospital. Why did they reach to the hospital? Because there is a clot at the fundus of the aneurysm. It blocks it. Those who continue to bleed, they would reach nowhere, they would die. But those who would develop a clot in the fundus, they will reach the hospital. Now your duty is to neutralize that aneurysm before it ruptures again. And CSF around the aneurysm has this ability to dissolve blood clots. So you need to operate quickly, immediately. The more you operate, the quicker, the better. And if you take the patient to theater, his aneurysm may rupture anytime. On induction of anesthesia, during opening the flap, during manipulation, etc. So you have to be prepared. You have to be prepared for the rupture aneurysm, not only to clip the aneurysm, but what to do if it ruptures. And one major principle of this is what we call proximal control. So, with the cerebral aneurysm coming from internal carotid. So I prepare the internal carotid so that if it ruptures, I can put temporary clip on it. I'm going to show another rupture of aneurysm, because this is the most frightening experience in your life, to face a rupture of aneurysm. You would wish you were never born. You would wish that you never existed, because you can do nothing. You cannot put an artery forceps. You cannot put anything. So you have to control yourself before you control the bleeding. So this is Manu. In case of middle cerebral aneurysm, you have to open the Sylvian fissure, and this is for the neurosurgical residents and young neurosurgeons. You open the Sylvian fissure always on the frontal side of the Sylvian fissure, not on the temporal. The circulation there is less than in the temporal. And as you see here, you can reach to the aneurysm. So again, the Sylvian fissure comes sometimes it's straight, sometimes it's wide, sometimes it's curving. You have to be prepared for all these eventualities. So let's see the surgery. It's going to be quick, I'm not going to take time. Remember, this patient came about 2 weeks after the rupture of aneurysm. Look at the brain, how angry it is. Very angry.
It was with what we said, vasospasm would be at maximum.
Absolutely, very angry. I cannot find a space to go in. But patiently, you would drain CSF, etc., etc., and then you start seeing the optic nerve, and then you see the carotid. You try to make sure that the carotid is there, available for you to put temporary clip on it if necessary. Now, the carotid is ready for me, there, optic nerve, carotid. Now I'm opening the Sylvian fissure. This is the way to open it. And as I'm opening, it will rupture. That's the aneurysm. You have to be prepared for this minute every time you deal with an aneurysm. It will rupture at a time you're not expecting it, at a time when you are looking around, at a time when blood pressure is up, and so on. So I have to open the arachnoid here, and as I do so, it will rupture. Nothing more frightening than this moment, but again, nothing more satisfying than clipping of an aneurysm. See, minor bleed. You say, okay, I'll continue. It does not stop. I want you to live these moments of fear that I have lived in that case. Bleed, it seems to be okay. Okay, let me cauterize that. Maybe you can make a clot on the fundus of the aneurysm. You put the bipolar, it opens more.
Squirting.
Absolutely. And now at this time, this is the dialogue between you and the anesthetic. Please take the blood pressure down as much as you can, as safely as you can. Hyperventilation or not, it does not make any difference because we are not dealing with brain edema. It is edematous, but I drain CSF. My concern is this, to lower the blood pressure so the bleeding is less, so that I can see, and then I can continue the dissection. Now, this is a very bad moment. It ruptures before I'm sure of what are the relationship of this aneurysm. I want to know, where's the fundus? Where's the branches, the temporal branches and the frontal branches of the middle cerebral? Where are they before I put my clip? And I tell you, there is nothing that you can do about it. So yesterday, I worked on putting these moments for you. So you see the horror movie that the clipping of aneurysm is. And sadly, that we are not producing any resident of any sort who knows anything about vascular anatomy or pathology or circulation or anything. We produce residents who shunt and disc. And this is not a neurosurgery. So an era, a group of neurosurgeons are coming out without any knowledge of this. Look at this clot, a very hard clot because it's 2 weeks. And I have to remove the hard clot off the fundus of the aneurysm. This is a clot on the fundus of the aneurysm. This is middle cerebral coming to me. This is the aneurysms here, but there is a clot on top. I want to see the branches around it. So I'm trying to dissect. And as you dissect, it will rupture again. Here you say, I wish I'm dead. I wish I don't exist. Why did I go into medicine? Why neurosurgery? Why me? You have all these questions in your mind. So that's the aneurysm, that's the fundus. But I want to put a clip here. I want to see the relationship. Again, I have the carotid ready for me to clip, but if I can manage without, that's better, because if I put here, then I have to finish quickly. Maximum 4 minutes. Put a clip on the carotid, come back to the aneurysm, dissect it, and clip it. If you can do it without, it's better. So if I put a clip, I say to the anesthetist, temporary clip is on carotid. So I start counting how many minutes. If I exceed the 4 minutes, you'd say, take your clip out. I take it out, it will bleed. And then I'll put it again until I finish my job. Aneurysm surgery is the top class of neurosurgery. And it is really hard. So I'm cutting the clot because it does not want to move. I really do so, but this clot was so hard that it didn't move. It's a clot, just very organized clot. Here you are, ruptured again. Here also you need a good assistant.
So how much blood did you end up giving?
It's not major blood loss, it is the blood obscuring your vision. You may bleed from your radial artery more than this one, but radial artery you can see, this you don't see. Radial artery you can put an artery clip on it, here you can't. It's a fundus. The whole fundus has ruptured. I've learned the trick from my boss that if there is a bleeding like this, you put the sucker on the fundus and let the suction pull the fundus, and then you can put your clip. And that's what I did. I used this trick which I learned, and here's my clip coming. I put it. The bleeding stopped. But I'm not happy about it. I'm not happy that I really closed the neck of the aneurysm. If I did not close it, this is incomplete clipping, like incomplete coiling. It will rupture again. So I bring another clip, and I adjust it. There's no escape. You don't say, oh, okay, I've secured the aneurysm. You didn't. You have to close the neck properly without closing the parent artery. Now I'm happy. Now, what Dr. Ramawia said, this, so I take the first clip and I keep the good one. In one of my cases that I did as a resident, it was a middle cerebral aneurysm. I put the clip on it. You could see the retractor here, retractor here. I put the clip, removed the retractors, closed the dura, closed the bone, and as we walked out from the theater to the ICU, I've noticed the patient is hemiplegic. So I called my boss. I said, sir, I've clipped the aneurysm, but the patient is hemiplegic. He said, let me see the video film. So I went to the video room, it was a big VHS thing, and we looked at the clipping. He said, very nice, beautiful clipping. And then when we removed the retractor, it was apparent that when you remove the retractors, the brain moved, the clip did. So it's not slip, but actually it angled the middle cerebral and blocked it. So I said, take him back and adjust your clip. Took him back immediately. Open his skull again, adjust the clip. He came out normal. Anyway, that's post-op. Glasgow scale was well, and he improved dramatically. He was discharged. And this is the skull X-ray. Maybe I put the answer for you to see the clip. You can see there and there. This is the CT scan. Usually there's an artifact because of the metallic nature of the clip. And this is what you see, is the so-called previous stroke that he had, which was a previous subarachnoid hemorrhage not noticed by anybody. This is him back to his office. I followed him up. 2002, I called him. He's back from Saudi Arabia, and I met with him. I did a brain MRI on him, and he was so well. So thank you very much. I was open for any discussion, any questions, any comment. Please. Dr. Mahmoud Nisam is a neurosurgeon qualified to sit for the exam.
Sir, why after TB you did not get approximate control?
Because I thought I can manage. It was not putting a temporary clip on the artery means that you have got into this 4 minutes window. I prefer to keep that option to the last. If I still manage, I better not to put the clip. And as I said, sometimes 4 minutes is not enough. So the anesthetist will tell you 4 minutes are off, finished. So I remove the clip. It will bleed, but some of blood will reach to the brain. And then I put the clip again and start all over again. Any questions, comments? If not, thank you, and we'll see you next Wednesday.